Good morning, everybody, and welcome to Semel Grand Rounds. I'm Tom Strauss, the Vice Chair for Clinical Affairs in the Department of Psychiatry, and it is my great honor to introduce to you my friend, colleague, and mentor, Michael Gitlin. As you know, Dr. Gitlin is a distinguished professor of clinical psychiatry here at UCLA and director of the adult division. He has also been interim director of the geriatrics division, and for some years, medical director of the outpatient clinics, the neuropsychiatric behavioral health services. Dr. Gitlin has also been director of our mood disorders clinic almost since its inception, approaching 40 years, and has trained more residents in mood-related psychopharmacology than anyone else I know. He's the author of more than 160 scientific articles, as well as book chapters in 5 books, including 2 on psychopharmacology for non-physician therapists called The Psychopharmacologist's Guide to Psychopharmacology, one with Vicki Hendrick, our colleague on psychotropic drugs in women, an author of The Clinician's Guide to Bipolar Disorder, and perhaps most salient to today's topic with David Miklowitz, the co-author of The Essential Guide to Lithium Treatment with Michael Bauer. Michael Bauer is his co-author. Michael Gitlin was chief of staff of the Resnick Hospital from 1997 to 1991 and has received numerous teaching awards here at UCLA and elsewhere. Today's topic, an update on lithium, I think is highly salient and a wonderful, wonderful talk. So it's my privilege to now hand the podium over to Dr. Gitlin for that purpose. Welcome.
Thank you, Dr. Strauss. Let me get my slides up. There, you should be able to see them. So what I'm going to do, it's the topic that is the same as Tom mentioned, but I've changed the title a little bit because that's what I'm going to talk about. Some clinical pearls that'll be more updates, some clinical management issues around side effects, organ toxicity. I'm going to focus some on some recent data on lithium and renal function, which is always clinically relevant. And then at the end, I want to go over some of the new uses of lithium because there's some interesting, really interesting new data about that. So let us start. First, how do you know who's going to get better from lithium? The estimate is no more than about 20% of bipolar patients have this great light bulb response to lithium. And the question is, do you know who they'll be? And the next 2 slides show you the predictors of good response for acute treatment, acute mania, and for maintenance. So for acute, it's basically the more the patient looks like the cartoon picture of mania, grandiose, euphoric, discrete episodes, hasn't had too many episodes, etc., not rapid cycling, not schizoaffective, not mixed. Those are the people who are going to get most better from lithium. If you look at what predicts a good response to maintenance treatment, it's as I show you here. This is from a vaguely recent 4-year-old review article. MDI refers to the pattern of episodes. So for most patients, they have mania followed by depression, followed by interval. That's the I, as opposed to DMI, which is it's depression followed by mania. Turns out the MDI people do better than the DMI people in lithium prophylaxis. Nobody knows why, but that's been shown in at least some studies. And again, absence of rapid cycling predicts a poorer response. Significant psychotic psychopathology predicts problematic treatment. Family history, lithium responsiveness turns out to be a familial, presumably genetic trait. So those are the kinds of things you'd look for to say who's going to do better on lithium. And here is from a 13-year-old study from Germany where they looked at what they called atypical features, schizoaffective, rapid cycling, mixed features, etc. And what you can see is the fewer of those features, that's the top line that's in black, those are the people who did best on preventive lithium. So that's an example of what I was just saying. All right. So a little bit on the practical aspect. So how should you, at this point in history, what should we do as pre-treatment evaluation? And I have a lot of things on this slide, and it turns out this is relatively culture and country specific. So Europeans do much more than most Americans, probably related to issues related to insurance and what gets paid for, et cetera. The minimum, it seems to me, would be a measure of renal function. If you get, a basic metabolic profile, they will spit out what's called the eGFR, the estimated glomerular filtration rate. In the old days, it was a serum creatinine, but now the eGFR is a more sensitive indicator, and the lab will spit that out. For thyroid function is absolutely required, and a baseline TSH, thyroid stimulating hormone, is really all you need. You can get a T3, you can get a T4. I'm not sure it adds a lot. So minimum is eGFR and TSH. You can get the other tests if you wish, but they're not, to my mind, required. How do you start it? If you're doing it on an inpatient unit, of course, you're going to do it much more quickly because you want to get people to the blood level quickly. If you're doing outpatient preventive treatment, you go more slowly. The slower you go, of course, the better the patient tolerates it and the less likely they are to start it. So it takes, for non-geriatric patients, about 5 days to get to steady state of lithium, which means if you want to start lithium and get to a level and you can trust that's the accurate level, you got to wait 5 days. Now, 5 days is a lot if you're on an inpatient unit. So it turns out if you look at the pharmacokinetic curve, you can cheat. And after 2 to 3 days, get a lithium blood test. 12 hours after taking the dose is always the right way to do it. And then add 25%. So after 2 to 3 days, you're not at steady state, but you're only about 25% down. So you can get that test quickly, add 25%, and you've pretty well estimated what the real steady state lithium level is going to be. For reasons that I'm going to show you in the next numbers of slides, you should try to get people on once daily lithium. The only reason to use it BID, twice daily, is if the patient gets early nausea from lithium, and then splitting it up, taking it after eating helps. But if they can do once daily, that's better, and I'll show you why in a little bit. So there are always questions about how do you do lithium levels? And there was a recent task force from the ISBD, the International Society for Bipolar Disorder. And here's the recommendation. First of all, 12 hours is the right answer. Why do we use 12 hours? Because it's in the middle of a flat part of the pharmacokinetic curve. So if it's 11 hours, it's 13 hours. It's not that big a deal. So 12 hours is correct. It turns out that if you take lithium 2 or 3 times daily, and then you switch to once daily, same dose, your lithium level is going to go up by about 25%. So how should you handle that if you're going back and forth? Which is the right level? And since we have no good data answering that question, the task force decided that don't worry about it. Whether you're on once daily or BID or TID lithium, just whatever the 12-hour level is, pay attention to that. It's not scientific, but it's the best we can do. A third area where there's been real changes in the last 10 to 15 years has been what's the optimal maintenance level? We used to target 0.8 to 1.0. It turns out, now that's very helpful, but side effects are more burdensome, and it's probably worse on organs like thyroids and kidneys. Therefore, now the general recommendation is that optimal maintenance level in non-geriatric patients is 0.6 to 0.8. So for me, the sweet spot, I'm looking for a level of 0.6, 0.7, less than we used to have. And that's good because side effects are minimized and organ toxicity is minimized. Almost no one needs a lithium level above 1.0. And if you're trying to prevent manias, depressions, mixed states, we have no data suggesting that one level is better than another. So the recommendation is the 0.6 to 0.8 is the right target level, no matter what you're targeting. As with pre-treatment evaluations, maintenance monitoring differs across countries. So again, in some other countries, like in Europe, they get all sorts of things like EKGs and CBCs. It's not obvious to me why you'd want that, what you would do with those data. For me, the issue is lithium every 3 to 6 months. If they're really rock stable, every 6 months is fine. TSH every 6 to 12 months, and a measure of renal function of now, again, eGFR every 6 to 12 months. I'm going to show you the data as to why serum calcium should also now be included. Anyway, we'll go over that in a little bit. All right, so now I want to switch to talking a little bit about lithium side effects. I'm going to talk about short-term issues, organ toxicities, then quickly about lithium and pregnancy. So first, not many people have no side effects from lithium, less than 20%, in fact. And we should divide side effects into the most common versus the most distressing. So the renal effects, the polyuria, polydipsia, thirst and urination, are the most common, excuse me, seen in about 70%. But in fact, the most distressing are weight gain and cognitive effects. Now, why is that a relevant distinction? Patients stop their medicine because of distressing effects, not common ones. And the weight gain and the cognitive effects are the reasons, the most common reasons why people stop lithium. The weight gain is significant. It's not as much as an example, olanzapine, quetiapine, valproate, all have more weight gain than lithium, but lithium is weight gaining. The cognitive effects are very much blood level related, far more at 1.0 than you're going to see at 0.5. Another reason to keep your blood levels low if possible. And sometimes the effects are subtle. So if you look across all the neurocognitive testing in patients on lithium, it's not obvious that lithium is cognitively impairing. That's incorrect. It is cognitively impairing, but sometimes it's subtle. And if you live in Los Angeles and practice in Los Angeles, as I do, there are a whole lot of people in the movie business here, and their ability to write, or musicians to think creatively, is critical. And there's good data showing that creative thinking is damaged by higher, not damaged, is minimized by higher blood levels of lithium. So in those creative patients of ours, keeping the level lower is also a very good thing. So if polyuria occurs because lithium affects the tubular function in the kidney, and you see it up to 2/3 of patients, not all studies. So how would you deal with it? First, keep the doses low and prescribe it in once daily effects. I'm going to get back to that in the next slide, but first let me talk for a second about how you treat lithium-induced polyuria, because it's a problem. So technically, diabetes, nephrogenic diabetes insipidus is NDI is 3 liters a day or more of lithium of urine. Now, it's hard to carry the little pail around with you and measure a full 24-hour urine. What do I care whether it's 3,200 cc's or 2,600 cc's? If it's a lot, if the patient is subjectively disturbed, then it's worth treating. And you can treat it with diuretics, thiazides, like 50 milligrams of hydrochlorothiazide, or amiloride, or since hydrochlorothiazide, you have to worry about potassium levels because potassium gets lowered by hydrochlorothiazide, you can use combination treatments like diazide, which is a combination of hydrochlorothiazide and triamterene, and therefore you don't have to worry about the potassium. Just so you know, if you do prescribe a thiazide, thiazides increase lithium levels by 25 to 30%, so you should lower the dose by a little bit. All right, before we get to tremor, let me talk a little more about why you should do once daily lithium. So there are a number of studies. Ironically, these studies are 40 years old, even though lots of people have not seen it. They were published mostly in European journals. This is a rat study. And the rat study, there were 3 groups of rats, those that just ate whatever rats eat, those that had lithium in their kind of little pellets that they ate, lithium-fed rats, and lithium that had intraperitoneal injections, rats that had intraperitoneal injections of lithium. Why is that relevant? The lithium-fed rats had pretty steady blood levels of lithium, like taking lithium 3 times a day, 4 times a day, sustained release. The intraperitoneal lithium rats had very high lithium levels, and then 23 hours later, very low trough levels, as if you were taking lithium carbonate capsules once daily. And then they looked at water consumption, which is a kind of a proxy for polyuria. And you can see here that the pink squares, the lithium-fed rats, had much more polyuria, implying much worse tubular dysfunction. That was also true if they sacrificed the rats, one of those terrible euphemistic words, and did blind renal biopsies, you also saw more structural changes. So this indicated that peak levels and low trough levels may be safer for the kidney. Then in Denmark, there was a study of 2 early lithium clinics that I show here. In one clinic, they gave once daily dosing, right? High peaks, low troughs. The other is 2 to 3 times daily dosing, again, a more steady level. And look at the difference in 24-hour urine volumes, dramatically higher with the BID-TID dosing. What that means is what the kidney needs is sometime during the day with a low trough level. And that gives it renal cells time to regenerate. So what that means is what you want to do is give once daily lithium of regular lithium carbonate so that 23 hours later, the level is low enough in the kidneys that renal cells can regenerate. And by the way, in the subgroup of people with renal biopsies, you can see similar issues. Once daily dosing had much more benign effects. Okay, so tremor. Beta blockers do work. Don't worry, please don't worry about making them depressed. The data are pretty clear that propranolol will only cause depression at high doses. I'm talking 160 to 320 milligrams a day. So in the kind of doses we tend to use for lithium-induced tremor, 10 to 80 milligrams a day, you're not going to make them depressed. So let us move on. All right. Nausea. That is one of the most, if not the most common early effect of lithium. And it goes away typically by itself, or you can have the patient take it after eating, where that also works. And the other trick is this is the one time it might be worth taking a sustained release preparation, these lithium ER, extended release. What that does is it makes it such that the lithium is absorbed more distally, more in the intestine and less in the stomach, less likely to get nausea. By the way, if you do that a few months later, it's likely that you can switch back to regular lithium carbonate capsules and you're going to do fine. Patient will do fine. How do you treat cognitive impairment? This is a real deficit in our field. We do not have enough data. It has not been sufficiently studied. I don't see any reason why we couldn't use stimulants, either the vigils, modafinil and armodafinil, Provigil, Nuvigil, or even dopaminergic stimulants. It's not the topic for the day, but there are data showing that patients who are on mood stabilizers are at no greater risk to switch if they're on the mood stabilizer and you give them dopaminergic stimulants like Concerta, like Dexedrine, like Vyvanse, like Adderall, if you can get the Adderall. For weight gain, the treatments of weight gain are no different regardless of the etiology of the weight gain. Diet and exercise, and when that doesn't work well enough, topiramate, metformin, and now, of course, everybody loves semaglutide. So Ozempic, Wegovy, drugs like that. All right, now let me switch to lithium organ toxicity. Then I'm going to talk about 3 organs, the kidneys, the thyroid, and the parathyroid. So first, if we think about renal function, this is from my vantage point as a psychiatrist, because I'm not a nephrologist, there are 2 parts to the kidney. There are the glomeruli that mediate the filtration function of the kidney, and the tubules, which does salt and water balance. And it turns out that lithium much more adversely affects the tubules than the glomeruli, which is why the polyuria and then secondary polydipsia, getting thirsty, is much more common than progressive renal insufficiency, which is a glomerular dysfunction. So initially, what lithium does is it causes increased urination by interfering with tubular function. very analogous, by the way, to what alcohol does, right? Everybody urinates more if you drink a lot, mediated through antidiuretic hormone, no biggie. If you stay on lithium, what was originally a functional issue becomes structural. And if you do biopsies on lithium, renal biopsies on lithium treated people, you see what's called interstitial nephritis, which is scarring of the interstitium, destruction of tubules with relative preservation of the glomeruli. So lots of patients will have lots of polyuria, tubular effects, but without having any glomerular problems, meaning their EGFR and their ability to filter is still fine. But eventually, if you have enough interstitial scarring, you are going to start knocking off glomeruli, and that's when you have problems. There's been an incredible number of studies, I'm going to show you a few in the next couple of minutes, about the long-term effects of lithium on the glomerular filtration function. It's that function, when it goes bad, where people go into progressive renal insufficiency and into end-stage renal disease. That is, by the way, exceptionally rare. It's not never, but it's really infrequent. I'll show you a little data about that in a minute. So yes, you see decreases in the GFR in patients on lithium, but it's not inevitably progressive, which is a good thing. At what point, a question would be, does the renal problem become bad enough that it's almost irreversible? And the answer is in an EGFR somewhere between 32 and 45. There are different studies. So an EGFR of about 40, you should be thinking hard about getting that patient off the lithium. And there's this recent study, the Hoekstra study from 8 months ago, showing that people who had EGFRs under 32, really, even if you stop the lithium, their renal function continued to decline, which you don't want to get to. There are these definitions which we don't, as psychiatrists, need to obsess about. Chronic kidney disease stage 3 is an EGFR of 60 or less, 4 is 30 or less, and end-stage renal disease, ESRD, which means you need to be preparing for dialysis or transplantation, is less than 15 milliliters per minute. It correlates with how long you've been on lithium. There are additive comorbid risk factors, diabetes, hypertension, the usual. The rate of stage 3 CKD is about 30% higher in lithium-treated patients than a control population. About 1 in 4 patients will get to that, but this is a slow-moving problem. The mean time to get to CKD3 in lithium-treated patients is over 20 years of treatment. And it is more than you see with valproate-treated people, carbamazepine, lamotrigine, etc. And again, what happens after you stop the lithium depends partly on how good your renal function was at the time you stopped it. So this is from a very recent study about 9 months ago. And it looked at patients on lithium, bipolar patients on lithium. And what I want to point out is there's a classic annual decline in EGFR that has to do with simply getting older. By the time you're 60, a third of your glomeruli have gone to sleep or rotted or don't function as well. So that's an inevitable consequence of aging. So you have to compare it to what is the mean decrease in renal function normally. And the group that stands out is this one. Look at greater than 10 years lithium exposure. And you see here that the annual decline in EGFR is 0.99 here, where it's really very similar to the population at large with less than that. So the renal problems with lithium is a long-term, very slow exposure to a nephrotoxic substance. This shows you exactly what the slide before does. This is on the right side, this is that greater than 10 years on lithium, and you clearly see the slope of the decline being dramatically different than the general population and people who've been on lithium for 10 years or less. So the Scandinavians have done an extraordinary job of computerizing their entire health system so they can do these incredibly large-scale studies asking questions that would be impossible in the US. So this is one with 2 regions of Sweden. It's just under half the population of the entire country. And they looked at what patients who were on lithium what the rate was of end-stage renal disease in those on lithium versus not. And you can see what it says. There were 24 patients, which was 1 in 200 patients, not 0. It's about 6 times the population risk. So the risk is there. The relative risk is 6 times higher. The absolute risk is still very low, 1 in 200 patients. And they had all been on lithium. They were all older, meaning 46 or more. And the average time of being on lithium was 27 years. So again, this is not something to dismiss as a non-issue. It is not something to be frantic about because it's still relatively infrequent. All right, moving on to thyroid function. Probably about 1 in 5 patients treated with lithium will develop some form of hypothyroidism. The reason the rates are so variable is it really depends on how you define it. Is it somebody with clinical manifestations of hypothyroidism, weight gain, hypersomnia, cold intolerance, hair thinning, etc., or is it just a high TSH? So the different definitions yield different prevalence rates. There's no doubt that lithium interferes with thyroid function. It inhibits thyroid hormone release, T3 and T4, and reduces iodine uptake, which is necessary to make T3 and T4 into the thyroid gland. Women are at far higher risk for this. The reason probably is that women have a far higher rate of autoimmune thyroiditis, and probably they have mild subclinical hypothyroidism, not important, and then you give them a thyrotoxic substance, and what was latent now becomes manifest. So to summarize, what do you do with it? Well, first of all, bullet number 2 is a key issue. If a patient who's doing well on lithium develops any form of hypothyroidism as manifested by a rising TSH, don't stop the lithium. Hypothyroidism, look, renal function is tricky. I mean, yes, we have dialysis and transplantation, but those are cumbersome, difficult treatments. Giving somebody L-thyroxine is ridiculously simple. So if somebody is doing well on lithium, do not stop it because they develop hypothyroidism. Either treat the hypothyroidism yourself or refer them to their primary care doc or the local endocrinologist. At what point in lithium treatment should you treat the incipient or progressive thyroid problems? And there's no clear right answer. Clearly, of course, if they're manifestly, symptomatically hypothyroid, of course you treat them. Top normal of TSH in our lab is in the high 4s, like 4.8, something like that. If the TSH is is just above that, like 5 to 10, you can treat or not, or monitor. If the TSH gets above 10, it's inevitable that they're going to become overtly hypothyroid. So at that point, you really might as well treat them with L-thyroxine. And again, either you can do it or refer them to their primary care doctor, but do not stop lithium because of thyroid issues if they're doing well from a mood point of view. The only new issue around organ toxicity is that of parathyroidism, or rather hypercalcemia and hyperparathyroidism. And these data are no more than 8 years old. It was only the study that I'm showing you now and some similar ones around then, about 8 to 10 years ago, that we started to realize it. And again, it was the Europeans who first saw this from their large-scale population studies. So this was one of the first studies from a catchment area of just under 500,000 people. And of the 400-something patients on lithium that they were evaluating, 1 in 5 had hyperparathyroidism, and 1 in 5 had a mild hypercalcemic picture. What were the predictors? How long you'd been on lithium, thyroid function, as if lithium affected endocrinological parameters in general, decreased GFR, and people who are older. The mechanism by which lithium causes is still a little bit obscure. It probably increases PTH levels through calcium reabsorption and stimulates the secretion of PTH. Most practice guidelines in our field do not recommend ongoing monitoring of calcium or PTH. I think it's inevitable that one day they will. None of us are particular mavens on how to treat hyperparathyroidism. This is why the Lord invented endocrinologists. They know what to do. There are indeed ways of treating it through medications. And of course, you can have a parathyroidectomy, but obviously if you can treat it with more benign treatments, you would do so. But if the calcium goes up and the parathyroid hormone goes up, just get an endocrine consult and you can talk about what to do. Let me do a brief spiel on lithium and pregnancy, and then we'll go on to issues of the new indications for lithium. So we used to think that that pregnancy was this time of better mental health for women. Turns out it's not. And if you do good studies, Adele Viguera at Harvard has done the best studies of the last 20-something years. And she has multiple studies following lots of women showing that if you go off your mood stabilizer, bipolar women go off their mood stabilizer, they're at clearly higher risk to have episodes. Let's also remember the baseline malformation rate in women who are on no medicines is 2 to 4%. That's the baseline noise against which you have to compare the potential effects of any medication. As with lithium and end-stage renal disease, the lithium's effect on the fetus has a high relative risk and a relatively low absolute risk. So you are 20 times more likely, a fetus exposed to lithium during the first trimester, to have cardiac abnormalities, the most common of which it's called Ebstein's anomaly, which is a complex set of structural abnormalities. The relative risk is 20 times the population rate, but the absolute risk is still low. It's only 1 in 1,000. Now, the rate of Ebstein's anomaly is 1 in 20,000 in the population. High relative risk, low absolute risk. The other key issue that everybody wonders about, of course, is since lithium has effects in the brain, that's why we prescribe it, is what are the effects on the developing fetus in terms of neurodevelopmental outcomes? And it is stunning to me how little that has been studied, given how important that is as an issue. Last year, I changed this slide because of this poll study that I show you on this slide, which only came out like about a year ago. Prior to that, the largest study was an N of 15, which was ridiculously embarrassing. Anyway, now we have one study with 56 lithium exposed kids who were exposed during their pregnancy when their mother took lithium versus 43 controls. And they were tested somewhere between age 6 and 14. And after adjusting for all the confounding variables, there was no difference, none, in any neurocognitive or neurodevelopmental parameter. No relationship to IQ, no relationship to lithium levels during pregnancy. This was great. So this is, and again, you can say 56 is still a very small number. I will not quarrel with you. 56 is a very small number for studies like this. The fact that they looked at all sorts of parameters and found absolutely no ill effects on any parameter is very comforting. Nonetheless, that's always something that we kind of need more studies about. So a summary, and I know that Dr. Unverfurth gave a talk recently in Grand Rounds on antidepressants and pregnancy. So for lithium, if you have a patient taking lithium during pregnancy, a bipolar woman, first of all, make sure that they drink enough, because if you get dehydrated, you become lithium toxic. We don't want that. You want to monitor lithium levels frequently as the pregnant women get larger during the second and third trimester. They have, as I love this phrase, a higher volume of distribution, and therefore lithium levels will go down. And sometimes you need to raise the dose to keep it at the low therapeutic realm of 0.6, 0.7. If you're worried about fetal cardiac effects, given what I just said, fetal echocardiography can pick up Ebstein's anomaly week 13, 14, 15 during pregnancy. You want to monitor TSHs so that you pick up if there is pregnancy, if there's hypothyroidism during pregnancy. So your lithium dose goes up because the woman is bigger. Right after giving birth, the volume of distribution goes down dramatically in 24 to 48 hours. And if you're not careful, the woman now taking a higher lithium dose can get lithium toxic. So you need to then decrease the lithium right after they give birth back to their usual dose. There are some authors who say you should go off lithium for 48 hours prior to giving birth. Most of us think that's a little extreme. If lithium is discontinued during pregnancy, you want to start it as close to giving birth as possible, because the postpartum period is so overwhelmingly the highest risk time for a mood episode, either mania or depression in bipolar women. All right, so how about breast milk? So lithium crosses into breast milk very easily. It's a very simple molecule, and it will be there at just under 50% of the maternal level, and neonates who breastfeed will have measurable lithium levels. They're usually not that high, but they're there. And remember, you don't have to decide breastfeeding versus not breastfeeding. You can do some breastfeeding, some bottle feeding, so that there's less exposure to the lithium, but the neonate is still getting enough breast milk for all the good reasons to have breast milk. There are occasional case reports of adverse outcomes, but not many. So this is a warning that you should think about lithium versus breastfeeding, but it's not an absolute contraindications. All right, I want to spend the last little bit of the talk talking about new potential indications, and there are 3 that I want to go over. First, I want to talk about lithium and cognition. This is ironic that we're talking about this because earlier I had said that lithium is cognitively impairing acutely, and you can measure it with neurocognitive testing. True. Ironically, at the same time, there is increasing evidence from cellular data and animal data and even little human data that I'll show you in a moment that lithium may be neuroprotective. So the irony is it affects cognition acutely, but in the long run, it's good for neurons, and it may actually prevent the development of dementias. So as an example, this Chen study that's about a year old showed that individuals, this is a large population study, that individuals who took lithium were at lower risk to develop dementia, both Alzheimer's and vascular dementia. And this is especially impressive because we know that the people who take lithium were bipolar mostly, that bipolar disorder may slightly increase the risk for dementias, and the people on lithium were less likely to get demented. So is lithium doing something neuroprotective? Then there's a second study published 4 years ago. This is a study where you take people with mild cognitive impairment, which sometimes progresses to dementia, but sometimes does not, and you put them on low levels of lithium, 0.25 to 0.5 were the levels they targeted in this study. And then you follow these people. And as you can see, those on lithium were less likely to progress from MCI, mild cognitive impairment, to dementia than those who were not treated with lithium. Again, indicating that lithium may truly be neuroprotective. Why would that be? Nobody knows yet, but it may involve telomeres. Some of you may remember that telomeres are at the end of chromosomes, they're protein complexes, and they are seemingly protecting the health of the chromosome, as it were. And when telomeres become shorter, it sets in motion a set of processes called apoptosis that may result in neuronal damage and even neuronal death. And it's a kind of a proxy for cellular aging. There is some evidence that lithium increases telomere length, and that may or may not be the reason why lithium is neuroprotective, even though it causes cognitive impairment. I think this is an extraordinary and fascinating thrust of research. This has not escaped anyone's notice in the lithium world, and you're going to see more studies about this. It would be so cool if we ended up giving older people lithium simply to protect their brains. That would be just a hoot. So that's number one. Number two is lithium is an anti-suicide medicine. Many of you may know that this has been an area for which there's been reasonable data for 20 to 25 years. There have been a paucity of actual RCTs, randomized controlled trials. It's mostly looking at patients who are on lithium, then looking at patients who go off lithium, looking at suicide rates, et cetera. And all of those early studies found that lithium absolutely decreased suicide. And the question was, well, one of the questions was, how much of this was due to the fact that lithium was just a good mood stabilizer versus did it really decrease suicidal behaviors, even in, let's say, non-bipolars? Okay. So let's go over this a little bit. So all these early studies said, yes, it was true. So then came this study 14, 15 years ago, again, from Europe, where it was the first randomized double-blind placebo-controlled trial in mostly non-bipolars. So it was 167 hospitalized patients who had made a suicide attempt. 80 to 90% of them were major depressed, not bipolar, and they were placed on lithium versus placebo and with whatever else they were on, and then just followed for a year. And as you can see, given that even in a high-risk population, suicide is a relatively low frequency event, but you can see there's a kind of a small signal that lithium prevented suicidal acts in these non-bipolars. Then came the first and really one of the only random assignment studies. This was from Maria Oquendo when she was at Penn. She's now at Columbia, I think. No, she's at Penn. She's at Penn now. And this was a remarkably hard study to recruit for. 98 patients, they wanted way more and they just couldn't recruit well enough, randomly assigned to lithium versus valproate, VPA, valproic acid, and followed for 2.5 years. These were people who were at risk for suicide attempts because they'd made them before. And as you can see, there was no difference. And again, this study is marred by the fact that it's just too small a study. 98 subjects simply may not be enough to power this study. But then there were these other naturalistic studies. Here's one from 6 years ago. Again, these population studies from Sweden, 51,000 people comparing lithium versus valproate that found that, in fact, patients treated with lithium had a decrease in their suicidal behavior, whereas the people treated with valproate had no difference whatsoever. Again, a naturalistic study. You can't control for all variables in that way, but that's interesting. Here's another study published 7 years ago showing valproate, olanzapine, or quetiapine, that's the higher gray line and zone, versus the lithium, which is the more of the tan line, and self-harm rates decreased in lithium versus those with the other mood stabilizers. So good reasons to think that this is a good thing. And then came the CAT study of 1.5 years ago, unfortunately. This was a large multi-center VA study, 519 patients. The results were so abysmal that they discontinued the study prematurely because statistically there was no chance that lithium could show efficacy. Mostly non-bipolars had recent suicide attempts and added to the treatment as usual, and they were treated for a year. The target lithium level was 0.6 to 0.8, as we've discussed, but in fact, the mean level was like 0.49. And that's a big issue. If you look at the data, absolutely no difference between lithium and placebo. So in this, the largest random assignment study, there wasn't a shred of evidence that lithium prevented suicidal events relative to placebo. But why was the lithium level so low? And it's not obvious why, because the target level was higher. Was it because doctors were wary about prescribing more lithium? Were patients wary of taking higher doses of lithium? Whatever it was, does this study really indicate that lithium doesn't prevent suicide? Or does this study really indicate that inadequate doses of lithium and levels don't prevent suicide? Unclear. There is a recent study that just was finished in Germany on using lithium for acutely suicidal inpatients, a randomized controlled trial. It's not published yet. And they found no difference also. That's acute. This is more, a long-term maintenance study. So the data on lithium and suicide were generally very positive, and recently there have been a few hiccups, and we're not clear what that means. And one of the most amazing findings is this one. And I really, deep in my soul, I don't understand it. That this was the meta-analysis of 14 prior studies done, published again about 2 years ago. Has to do with lithium in drinking water. Now, we know that lithium comes from rocks. Most of the lithium that our patients take is from the Atacama Desert in northern Chile, because there are rocks there that have a lot of lithium in it. That's where you get lithium. In reservoirs, the rocks surrounding the reservoir have variable amounts of lithium, and you can then measure the amount of lithium, and these are teeny little amounts of lithium in the drinking water. And there have been now 14 studies looking at an incredible number, 94 million people, looking at what are the rates of violent episodes, psychiatric hospitalizations, and suicides, correlating it with how much lithium is in the drinking water. Now, again, if you measured the lithium levels, even in people drinking water from the reservoir that have relatively high rates of lithium, their lithium levels would be non-detectable. It wouldn't even be 0.2. It would be so trivial that it would be unmeasurable. It's not zero. It's just not detectable. It's below the assay sensitivity. And yet, despite these trivial concentrations of lithium, those counties or communities that drink from the municipal water that has higher rates of lithium concentrations have lower suicide rates. So that's kind of interesting. So a fantasy, not a recommendation. Given what I was saying before about lithium at low doses, 0.25 to 0.5 was that Forlenza study I just showed you, and given the lithium in drinking water, will there come a time that we take lithium like we take vitamin E or baby aspirin or whatever, that just teeny little amounts of lithium to protect our little telomeres in our neurons, or to make us less impulsive, less suicidal, less violent? That would be a hoot. And maybe that would be one of the uses of lithium orotate, this very, very low lithium preparation, which I would not use for bipolar disorder, because for bipolar disorder, you got to get lithium levels at 0.6. Levels of 0.2 are not going to work. But for these other indications, like suicide issues, potentially, and certainly neuroprotective effects, maybe we could get by with teeny little lithium levels. That would be wondrous. And this, again, shows you from the same review paper, the 14 studies showing that lithium in the drinking water really is associated with lower rates of suicide. So to summarize, and then we'll open up for questions. There's a subset of bipolar patients who have an incredibly robust response to lithium, generally estimated in around 15 to 20%. There are a larger subgroup that have a partial response. So we still use lithium a lot. Lithium side effects exist. They are potentially problematic, but they're manageable, and you can manage them with keeping people at low therapeutic lithium doses, and therefore low therapeutic lithium levels, and also then treating side effects like the polyuria, like the tremor, if you need to, like the nausea, if you need to. But probably keeping lithium levels low is the single most important factor. Yes, monitoring renal and thyroid and calcium are probably optimal ways of dealing with lithium. And you should monitor them, treat the thyroid if hypothyroidism, if it occurs. For the renal issues, monitor it when the eGFR gets below 60, maybe have a nephrologist follow with you and figure out what to do and whether the patient could stay on the lithium. And to me, the most exciting part of this whole field is the potential neuroprotective effects. of lithium. If that turns out to be true, that would be a game changer. So with that, I will stop and take questions from the audience that Dr. Strauss will mediate.
Well, Dr. Gitlin, thank you for a really enticing and interesting update. I learned a lot, and our audience has been stimulated to ask a number of questions, and I have a few for you as well. There have been a cluster of questions about the low-dose lithium and perhaps protection against dementia question, and indeed one of the listeners asked specifically about this issue of lithium orotate available in health food stores, and the question was, is there a known lowest dose of lithium as sort of as a preventive? Do we know anything about what's in the health food doses, et cetera?
Yeah, well, the problem is we don't. That Forlenza study that I showed you, the lithium levels were targeted at 0.25 to 0.5. What would happen if there's a study where the lithium level was 0.1, which is probably, I don't know, 150 milligrams a day or 300 milligrams every other day? We don't know. What I wanted to show you was that that the early studies, both the rat studies and the human studies, are suggestive enough that the exact question that this audience member asked should be addressed. And I guarantee you there are going to be more studies on low-dose lithium and its neuroprotective element, because if you could get neuroprotective effects with a lithium level of 0.1 or even less, there may be no organ toxicity at all for that. Maybe you don't even need to worry about anything. That would be a game changer.
Very interesting. Thank you. A related, well, actually unrelated question, but from the same listener, the CAT study, which I think was that VA study that you referenced that unfortunately showed no anti-suicide protective effect with lithium. Was there any that you know of any sorting out of patients based on blood levels or lithium doses?
Yeah, seemingly not. There may be some sub-analyses that would look at it, but the adherence rate was so difficult in that study. You know, people don't comply with lithium treatment frequently, and the vets in that study surely didn't. So the answer is no.
Okay, very good. What about any known correlation between lithium and not diabetes insipidus, but diabetes mellitus? Is there any connection between lithium and diabetes mellitus?
None that I'm aware of. The only thing to say is you see polyuria with diabetes and with lithium effects. And if you look at those studies at the very infrequent patients who really have renal damage and go towards at least end-stage renal disease, the additional risk factors include hypertension and comorbid diabetes. So it's not like lithium affects the diabetes or vice versa, but they're both independent risk factors to renal damage.
Very good. Very good explanation. That's really clear. Thank you. This is a little creative psychopharmacology. The question is, does a banana at bedtime, I assume related to the potassium concentration, reduce lithium-induced polyuria?
Well, first of all, it's not the potassium that necessarily does it.
Okay.
The issue with the potassium is that hydrochlorothiazide, which is a very good treatment for lithium-induced polyuria, lowers your potassium. And because it lowers your potassium, you have to worry about it, etc. If you keep the potassium up through either eating a lot of bananas or just taking a potassium-sparing diuretic, at least you don't have to worry about the potassium. But it's not that potassium prevents polyuria. It prevents the psychiatrist from worrying about the potassium level. And I actually don't know how many bananas a day you would need to offset the effect of hydrochlorothiazide on potassium levels.
All right,
That's
very
a
good.
terrific question.
Well, to persist a little bit more on lithium and ions, there's another question about monitoring calcium. Particularly, the assertion is that when you're following calcium in lithium patients, ordinary calcium levels can be normal while ionized calcium may be elevated and would not necessarily show up on an ordinary comprehensive metabolic panel. So the question is, how often might one get ionized calcium? And should one get an IPTH? I'm not sure what IPH stands for in this query.
I think those are terrific questions and are beyond the knowledge base in our field. As you may have noticed when I was showing you the studies, those were large population-based studies where all they measured was total serum calcium. So it could be, as the questioner suggests, that ionized calcium would be a much more specific risk factor, and maybe we should end up measuring that instead of total calcium, but nobody has looked at that yet. Again, I suspect, because remember, as I showed you, these studies are only the last 8 years. We've known about lithium and kidney stuff for almost 50 years. The calcium stuff is less than 10 years. So there's still a fair amount of work to do in figuring out what's the optimal way to monitor calcium parameters, ionized versus total, PTH versus calcium, etc.
Thanks very much. Moving back to your excellent summary about lithium in pregnancy, the question comes up as to whether the so-called soft recommendation to change lithium dosing from once daily to BID simply to lower peak plasma levels. Apparently that's a bit of wisdom that was passed on to someone. Is that valid?
That's a tricky question. The answer is that's good common sense, but I'm not aware that anybody has good data on that. Now, just to say, the issue about doing lithium once daily, as I think about it, the answer is we don't know. I mean, the idea of avoiding peak levels to minimize that exposure to the fetus is one factor, but you also want to protect the mother's kidneys. So those may be in some conflict.
Interesting. Okay. Dr. Miklowitz asked, is there any evidence that lithium reduces substance and or alcohol abuse or relapse, which might in turn reduce suicidal events?
The answer is no one knows. There is a little bit of data on valproate in bipolars who have a history of alcohol abuse or dependence, that valproate may be useful in that group. I am not aware of any similar or parallel data with lithium-treated patients.
Okay, very good. Thank you. A question about lithium in adolescents and young adults. Does the renal side effect profile of lithium make it perhaps less favorable or attractive to use in bipolar disorder in adolescents and young adults?
Yeah, it's a tricky business. So remember I said that about 20% of people have what I think of as a light bulb response to lithium. I mean, they are so dramatically better. And for those people, even if they're adolescents, it seems to be worth putting them on lithium and keeping the levels low, like 0.6, 0.7. But remember, there are a lot of people who have only a partial response to lithium or no response. And for those people, we should probably get them off. But if somebody has clear adolescent onset florid bipolar 1 and has done well on lithium, I would just keep my levels low and keep them on it.
All right, I'm going to permit myself a question because I have many, which we'll have to talk about after this is over. And this one has to do with lithium for acute mania. I followed closely your comments about optimal serum levels for lithium for prophylaxis against mania, for treatment or prophylaxis against depressive relapse. I didn't see mention of ideal lithium levels in acute mania. There was a time when we were taught, I think you might even have taught me this, that higher lithium levels for, let's say, a hospitalized adult with acute mania might be necessary to bring the mania under control.
That is still correct. I just, for time reasons, I didn't have that in this talk, but optimal levels in non-geriatric patients for treating acute mania are probably 0.8 to 1.0. There's a little bit of naturalistic adolescent data that adolescents tolerate and may need even higher levels, like 1.2, 1.3. But for adults, 0.8 to 1.0 is reasonable. And then once the mania resolves, you want to get the blood level down for all the reasons I mentioned.
So we've said goodbye to 1.2 to 1.5 ranges. That's old history, never more.
Indeed.
All right. Well, it is noon, Dr. Gitlin. The Q&A was really fun. The talk was spectacular. I will encourage those who didn't get their question answered to perhaps write to you directly.
Sure.
And thank you. It was just terrific.
You're very welcome.
Thanks everyone for participating.
Always happy to be here. See you guys again. Aye.